Welcome to our discussion on human immunodeficiency virus-associated mitochondrial dysfunction and its link to metabolic complications. We'll explore whether human immunodeficiency virus-associated mitochondrial dysfunction is the underlying cause of weight gain and metabolic diseases in people living with human immunodeficiency virus, and the role ultra-processed foods may play in exacerbating these issues. Antiretroviral therapy has transformed HIV into a manageable condition, allowing life expectancies similar to HIV-negative individuals. However, people living with HIV face higher rates of non-AIDS illnesses, including metabolic diseases like insulin resistance, non-alcoholic fatty liver disease, and cardiovascular issues. This phenomenon, termed inflammaging, suggests a link between HIV-associated mitochondrial dysfunction and ultra-processed foods as potential accelerants. The return to health hypothesis suggests weight gain in people living with HIV on antiretroviral therapy is due to restored health, but it doesn't explain ongoing visceral adiposity and metabolic issues. Lipodystrophy presents as lipoatrophy or lipohypertrophy, with body mass index often underestimating adiposity. Certain antiretroviral therapies, especially integrase strand transfer inhibitors, are linked to new-onset diabetes, indicating a pharmacological impact on metabolism.
Spend a minute looking at this figure of the possible causes of weight gain in HIV patients.
Weight gain in people living with HIV on modern antiretrovirals is complex. Integrase strand transfer inhibitors may disrupt appetite regulation, while antiretroviral therapy and inflammation interfere with insulin signaling, leading to fat accumulation. Reduced energy expenditure and access to ultra-processed foods exacerbate this. Additionally, adipose tissue immune activation and HIV proteins contribute to mitochondrial dysfunction, promoting obesity. Insulin resistance is the initial molecular event in metabolic dysregulation for people living with HIV. It begins with resistance in muscle, liver, and adipose tissues, leading to hyperinsulinemia and fat accumulation. Causes include HIV-associated metabolic disorders, nicotinamide adenine dinucleotide depletion, chronic inflammation, antiretroviral therapy drug effects, and dietary factors, creating a complex network of contributing factors.
Please take a moment to review Figure 1 of the causes of hyperinsulinemia. Press pause in the video and digest it. It took me forever to make this graphic.
HIVAMD, or HIV-associated mitochondrial dysfunction, accelerates aging in people living with HIV, distinct from the general population. Integrase strand transfer inhibitors contribute to increased visceral fat and mitochondrial impairment. Impaired oxidative phosphorylation leads to energy deficits, disrupting insulin signaling and causing lipid accumulation. Excess reactive oxygen species from dysfunctional mitochondria further amplifies insulin resistance, creating a challenging cycle of metabolic disease and mitochondrial damage. Human immunodeficiency virus-associated metabolic disorder drives insulin resistance through 6 interconnected pathways. Reactive oxygen species-induced insulin receptor substrate serine phosphorylation, nicotinamide adenine dinucleotide depletion affecting sirtuins, impaired oxidative phosphorylation reducing insulin secretion, altered mitochondrial dynamics, and ectopic lipid accumulation forming ceramides/diacylglycerol. These pathways operate simultaneously, complicating treatment. The serine kinase pathway and nicotinamide adenine dinucleotide/sirtuin axis offer promising targets for future interventions. Ultra-processed foods, especially those high in fructose, exacerbate human immunodeficiency virus-associated metabolic dysfunction. Socioeconomic disparities limit access to nutritious foods for many people living with human immunodeficiency virus. Fructose metabolism primarily occurs in the liver, leading to metabolic damage. Excessive fructose is linked to non-alcoholic fatty liver disease, insulin resistance, type 2 diabetes, obesity, dyslipidemia, and hypertension. Methylglyoxal, a byproduct, harms mitochondrial function.
Pause the video and look at the metabolic pathways of the devil fructose, mainly in the liver.
Methylglyoxal, MGO, glycates mitochondrial components, degrading the electron transport chain and impairing energy production. It inhibits manganese superoxide dismutase, increasing oxidative damage. MGO also inhibits electron transport chain complex 3, reducing adenosine triphosphate production. Additionally, MGO promotes aging hallmarks like systemic inflammation and genomic instability, exacerbating mitochondrial damage in people living with human immunodeficiency virus and accelerating aging. Fructokinase phosphorylates fructose, depleting adenosine triphosphate and accumulating adenosine monophosphate, which activates adenosine monophosphate activated protein kinase. Initially, this boosts glucose transport, fatty acid oxidation, and autophagy. However, chronic fructose intake leads to methylglyoxal accumulation, inactivating adenosine monophosphate activated protein kinase. This results in insulin resistance, increased lipogenesis, and metabolic syndrome. Adenosine monophosphate accumulation also drives uric acid synthesis, linking fructose to hyperuricemia and hypertension. Microbial translocation in a compromised gastrointestinal mucosal barrier is crucial in human immunodeficiency virus pathogenesis. Human immunodeficiency virus and fructose reduce tight junction proteins, increasing intestinal permeability. Translocated lipopolysaccharides activate toll-like receptor 4, causing systemic inflammation. Human immunodeficiency virus-associated dysbiosis, with a predominance of proteobacteria and Prevotella, leads to metabolic complications. This microbial translocation also causes endothelial dysfunction, contributing to human immunodeficiency virus-associated neurocognitive disorder across multiple organs.
Take a look at the leaky gut. You can easily realize that if you don't close the sink, you will never reach a functional cure. RT ain't enough at this level. Human immunodeficiency. Virus-associated gut dysbiosis, excess fructose, and human immunodeficiency virus-associated metabolic dysfunction create a hostile metabolic environment in people living with human immunodeficiency virus. Concerned, fructose worsens microbial translocation and dysbiosis, damaging tight junction proteins and fueling inflammation. Decreased short-chain fatty acids impair mitochondrial function, compromising barrier integrity. Size. Leaked microbial products like lipopolysaccharides cause mitochondrial damage, extending metabolic consequences beyond the gut. The Western diet's omega-6 to omega-3 imbalance, with a ratio nearing 30:1, promotes inflammation. Concerned, excess linoleic acid from processed foods impairs mitochondrial function, induces apoptosis, and activates the NLRP3 inflammasome. A balanced ratio of 1:1 to 3:1 may reduce inflammation, crucial for people living with HIV facing additional metabolic challenges. Early screening for metabolic disease is crucial, especially before starting integrase strand transfer inhibitors, or tenofovir alafenamide fumarate. Thoughtful standard tests like fasting glucose and hemoglobin A1C may miss early insulin resistance. Instead, use homeostatic model assessment of insulin resistance, fasting insulin levels, waist measurements, and dual energy X-ray absorptiometry scans for accurate detection in people living with HIV. Informative. These methods identify issues before hyperglycemia and provide a clearer picture of metabolic health. Intermittent fasting and early time-restricted feeding are promising interventions for reversing hyperinsulinemia and improving insulin sensitivity. Thoughtful glucagon-like peptide 1. Receptor agonists like semaglutide and liraglutide need evaluation in people living with HIV. Metformin and tesamorelin also require further study for their potential benefits in managing HIV-associated metabolic complications. Critical evidence gaps hinder clinical guidance on HIV-associated metabolic disorders. Thoughtful. We need randomized controlled trials on dietary interventions, studies on supplements like nicotinamide, adenine-dinucleotide, and coenzyme Q10, and longitudinal homeostatic model assessment of insulin resistance data. Research should focus on community settings, involving community hospitals and nonprofits, with robust government and non-governmental organization funding to ensure inclusivity and relevance. Human immunodeficiency. Virus-associated mitochondrial dysfunction is a key factor in metabolic disease for people living with human immunodeficiency virus, driving insulin resistance and metabolic syndrome. Concerned, ultra-processed foods exacerbate this through various mechanisms. Early screening with fasting insulin and homeostatic model assessment of insulin resistance is crucial. Urgent. Urgent research on lifestyle and pharmacological interventions is needed to address these challenges effectively.